Dr. Olsen, I want to start with you here. You work with such a range of populations in your role at SAMHSA, and I wonder if you could center this conversation by helping the audience here understand why it's so important to think about incarcerated peoples and in this broader discussion about opioid use disorder and expanding treatment.
Yeah. It's such a great question, and Brendan actually highlighted it, that this is a population that has just incredibly high risk of mortality, mostly from opioids, particularly illicitly manufactured fentanyl, particularly upon re-entry from incarcerated settings. But even within carceral settings, that mortality can really be significant. When people are experiencing opiate withdrawal, it is associated with increased risk of suicide. And so this is really one of those populations that when we think about having impact on the overdose mortality curve, this is one of those top priority populations.
And Dr. Potee, you are our boots on the ground in this conversation, actually working in a jail in Massachusetts. I wonder if you could tell us what are some of the challenges you have seen in getting treatment to the patients at your jail?
So I think folks know that when you're working in a jail, you're taking care of patients who have, by and large, high mental health diagnoses and huge substance use, whether it's alcohol or opiates or methamphetamines. 80% of the people at my jail are there with a substance-related crime. And if you're not actually providing them the treatment they need, then they're just going to recommit crime and cause harm to themselves and society. So it's absolutely critical that we have low barrier access. And the problem, for those of you who don't know, is you can't just prescribe methadone to a pharmacy and have it get delivered to your jail or prison. And thanks to the excellent work at SAMHSA under Yngvild Olsen's leadership, and this has been the best SAMHSA we've ever had, the rules were rewritten, and they added 3 words, and jails and prisons, to one paragraph. The same paragraph that allows a hospital to use methadone, jails and prisons in our country can now do that. It's amazing.
Dr. Olsen.
So, I think one of the things that, as Ruth was mentioning, that, we were able to clarify, actually, in the rule, an existing DEA regulation. And obviously, I can't speak for the DEA, but essentially that then does designate correctional facilities, so jails and prisons, as similar to hospitals when they have a hospital/clinic designation where they can provide both continue as well as start methadone outside of not having to have kind of that narcotic treatment program credential, not having to have the OTP credential from SAMHSA, as long as the OUD, the opiate use disorder condition, is secondary to another primary health condition, and secondary to a health condition other than addiction. So what that means, and the impact of that, is that can absolutely expand access to methadone treatment, not only for people who are on it in the community and then who get incarcerated, particularly in jails where there's just an incredible turnover and you just don't have time to really provide all the services that otherwise is available in opioid treatment programs, but also in prisons and as part of kind of an integrated health system. And so it adds another option in the toolbox for really being able to provide access to all 3 FDA-approved medications for opioid use disorder. And that added kind of having access to all 3 is so incredibly important. We know from research in Rhode Island and other places that when people have options, when they have the choice of being able to take the medication that they think is going to work best for them, that's where we really see the uptake of the medications for treatment and where you see the reductions in mortality. In Rhode Island, it was up to 61% reductions in mortality for people who were re-entering into the community compared to the general population when they really had that access to all 3. So that is just, I'm just very excited about the potential impact of this. The rule was passed earlier, released earlier this year, took effect, compliance date was October 2nd. So we're doing a lot of implementation work right now to really get the message out, not only because we changed wholesale, kind of substantively, really a lot of the pieces in the rule, but this one in particular, I think, is really an incredible opportunity to really be able to make a difference.
And because this is a public health conference where people are focused on science and outcomes, it isn't just outcomes related to overdose death. There's more studies funded by JCOIN and other federal government agencies on the 2 states, Massachusetts and Rhode Island, that universally have rolled out treatment in jails and prisons that look at a 40% reduction in recidivism. Those are huge numbers when it comes to recidivism. You don't see anything that changes the course that people's lives take once they're incarcerated once. So one of the challenges I would throw out at you is, do you know what your local jail or prison does for people with opiate use disorder? Most often people have no idea. Most often people actually have no idea who their local sheriff is. And your local sheriff, by the way, runs your local jail. And I would challenge you as public health people that care about people who struggle with substance use disorder, that this is the area, more than any other area, where you can alter somebody's life and outcome. And I would also argue that jails and prisons should be run by public health officials. You hire somebody who's in charge of security, you can do that, that's fine. But the reason I'm up here is because I have a sheriff who's a public health guy. And he said to me in 2015, I said to him, we need to get buprenorphine in here, and he nodded his head and said, you're in charge, you're the medical director, make it happen. And so we have been doing methadone and buprenorphine, and we're a fully licensed methadone clinic because I had the leadership of a public health-oriented human.
Dr. Potee, I want to stay with that for one more moment. It's not just access to the treatments, but people who are able to care for the patients in the facility. What workforce shortages are we grappling with right now that might affect this broader question of access to treatment?
It's hard to work in a jail and prison. I don't know who in this room does it, but there's a lot of moral injury when you work in a place like that. They can be dangerous, they can be violent sometimes, but for the most part, you're actually taking care of people who are your friends and neighbors and your kid's nephew. And when you are watching people suffer with either an untreated mental health diagnosis or an untreated substance use disorder, it is very hard to show up at work. And you know who supports treatment at my jail is security. They want people on treatment because it's much better for them. We have fewer disciplinary reports. It's less harmful for our correctional officers. They're safer. And so once you get real buy-in, it works. The problem is the pushback on buy-in is enormous. And when you're trying to influence an entire state, the state of Kentucky has 120 counties. They have 84 county facilities. Tell me how you're going to affect that state. State by state has got to say this is a universal required program in our state.
Dr. Olsen, we have the federal efforts, many of which you're leading. We also have an influx of opioid settlement dollars that are reaching state governments, local governments, many of which are also trying to expand access to treatment in these settings. How is this all coming together? It's a bit of a patchwork, and what would you like to see for the next few years?
Yeah, so I can really kind of speak to I think what we've been seeing from the federal government and how we've been working with states around particularly braided funding. I think using opioid settlement dollars, we provide states with the state opioid response grant dollars as well that can be used, and many states are using those dollars also to help support access to treatment for substance use disorders in their jail settings. And this is a great place to really be able to actually combine federal, state dollars, local dollars, and have this evidence-based practice really be able to have a huge impact on communities.
And a final question to you, Dr. Potee, because we are out of time. I wanted to ask, President-elect Donald Trump has really focused on opioid use disorder and the broader opioid epidemic in terms of law and order more so than public health. And I know you just mentioned that all jails and prisons and incarcerated settings should be run by public health officials. What do you anticipate from the next administration?
I'm like the rest of you. I live in fear, and I'm also, I have a giant question. Having said that, SAMHSA rules take years and years to change and rewrite. So I think we're good there. Thank God for that. And then, the other thing about jails is they're hyper-local. And the federal government has no idea what's happening at your county jail, quite honestly. It's so far down their list of things they want to wreak havoc on. We may be okay. So let's make an impact on your local jail and your state corrections facilities. That's how we can do it. The Federal Bureau of Prisons is the largest methadone clinic in the entire country. So we already got the federal BOP on board, and they can't take that away.
And on that note, that is our time. Thank you so much. Appreciate it.